So we are starting our today's session. Bismillahirrahmanirrahim. And today I was deciding, as per our routine in the Sunday free classes, weekend free classes, that I should be doing two cases. That is one clinical consultation and one clinical communication.
Yes,
So I was planning according to that, but in the last moment, I was deciding that we should do something, you can say different today. And the thing which we have never done before, slightly unconventional, and because such type of challenges are often popping up in the exam, so that's why I was planning that case. I was working on that case, and I am deciding that instead of doing the two cases today, we should be focusing a lot and deeply on one clinical consultation. And if you people can pay attention over there, and if you people can focus over there, inshallah, it will not teach you only one case. Other, I promise you that it will be covering more than your five or six cases. So it will be quite an intensive case today, and we will be focusing today on the one case that is our clinical consultation. So better is that we should have a quality teaching and quality learning instead of running fast and missing important piece of information. So Dr. Gailan, I believe and I hope that my voice is getting loud to you.
yes, sir, it's clear.
Good. So I am giving you this case, and this case you should be preparing it for at least 4 to 5 minutes, and then I will be giving you the timer, and you will be performing this case, and you will have the 15 minutes with your patient, and after that it will be followed by the viva examination. Clear?
Yes, sir. Yes,
So
sir.
first of all, before we are going ahead towards our session, kindly let me know that are you able to see and read my screen quite clearly?
Yes, sir. It's
Okay,
clear.
what the words are clear to you or they are blurred?
All clear, sir. I think it's quite clear.
That's quite good. Okay. So now I am giving you your case. Please prepare it very well. And then we will be starting doing this case. It is a really high yield case and sometimes posing quite challenges for our students. So have a look. Dr. Gailan, are you ready?
Yes, sir.
Okay,
Okay.
just give me a second. Just give me a second. Just give me a second, please. So, I think we should be starting now. Okay, so Dr. Gailan, I am giving you your timer, and your time starts now.
Okay, sir. Hi, good morning, sir. My name is Dr. Gilan. I'm one of the doctors in the department. Am I talking to Mr. Zia, 60 years old?
I'm Mr. Zia, and I'm 60 years of age.
Okay, nice to meet you, sir. I'm here today to talk about some of your symptoms about your health condition. Is that okay with you?
Yeah, fully okay with me.
Okay, sir. I have. It comes to my knowledge that you complain of some loose motions and tummy pain. So, can you just tell me more about that?
Yes, I am having some sort of loose motions and with some sort of abdominal pain. And it is now quite there for about last 3 months.
I'm so sorry for that, sir. Do you have any pain now that we can help you with any medication?
No, it's better now.
Okay, so you said that it's for the last 3 months. Okay, is that the first attack that you have these symptoms?
Yeah,
First
this
time.
is happening very first time.
Okay, so if I ask first about the loose motions, how many times you have loose motions a day, and how it
I'm at
started?
least having them for about initially they were 2 or 3 times per day. But I am going to washroom now more than 4 or 5 times.
Uh, if I ask about the amount of the, is it let's say large amount or it's a small amount?
It is quite a large in amount.
Okay, is there any let's say slime or blood with it?
Yes, bleeding. Bleeding happened, I believe, 2 times only.
Two
And
times.
sometime I am also passing slime, but not much.
Yes, yes, sir. If I ask about, is there any, let's say, about the this stool type? Is it floating on the in the toilet, or is it washed easily?
No, it is not floating.
Okay, is it oily or not?
No.
Okay, so about the, is there any, is there something that can makes it more frequent and aggravates it?
I have not noted anything like that.
Okay. During this time, did you do anything to reduce the or to treat the loose motion?
Mm, no. I was trying pyramid, but it is helping me sometimes, not always.
Okay, sir. Then you talked about in the last 3 months you have also tummy pain. So if we talk about the tummy pain, is it at the same time or precedes the motion?
Tummy pain is there regardless of the loose motions. It is always there with me.
Yes. The duration. I mean, it is precede the motion or together they come.
It is all the time with me, even if I am having loose motions or not.
Yes, sir. About the site, exact site of the tummy pain. Where is the pain exact?
I am having it. Patient is touching middle of the abdomen.
Yes, sir. Okay. About the pain, is it progressive or it is the same throughout that time?
It is almost same.
Okay, sir. About the character of the pain, is it continuous or it is intermittent? Uh,
It
how is
is
the pain? If you can
it is a dull, boring pain.
yes. Is there any thing that aggravates the pain, such as a meal, such as any movement, anything?
No, I have not noted anything like that.
Okay. About the timing, if I ask, is there any relation between the loose motions and the tummy pain?
No, nothing like that.
Okay. Did the motions relieve the tummy pain, or it remains the same?
Nothing like that.
Okay. Okay. So, sir, if I ask about the severity, and if I grade it from 1 to 10, can you grade it to me the grades of the severity of the pain?
I can say that it is almost 6 out of 10.
Yes. Okay. So, and it remains the same.
Yes.
Okay. Sir, if I ask about did you lose any weight throughout this time?
Yes, I have lost some weight.
Okay. Is it intentional or non-intentional?
It was totally unintentional.
Okay. Do you have any idea it's how many kilograms you lost?
I have lost about 6 kilogram of weight over 3 months.
Okay. Okay. So that's significant. So, sir, you've lost that kilograms, and about your appetite, is it changed or not?
Appetite is normal.
Appetite is normal. Yes, sir. If I ask about, do you have any temperatures, high temperatures?
I am not having high temperatures, but yes, I am having low grade fevers.
Yes, sir. So, if I ask about the any night sweats, any heavy
Yes, I
sweating
am
during the night?
also having night sweats.
Yes. And sir, if I ask about your did you have any problems at the mood in the now or in the past? Any change in your mood?
No issues at all.
Okay, sir. Sir, if I ask about the any feeling sick or being sick, any change in your color of the eye?
No,
Any change with your swallowing of the food, difficulties with the swallowing or pain with the swallowing?
no,
Do you have any heartburn, any
no,
gastric pain? Okay, so do you have any swelling in the tummy?
no.
If I ask, sir, about the any change of the color of the stools, you said that you have loose motion, but is there any change in the color?
Color change happened twice. Twice I got bleeding over there.
Yes.
Otherwise, it is normal, routine, colored, loose motions.
Yes, sir. Okay, sir. Now, if I ask a few questions about the background, your background, some general questions. So, do you have any chest pain or any palpitations, any feeling of your heartbeat,
No feeling of the heartbeat and no chest discomfort.
any cough, any shortness of breath?
No.
Sir, do you have any, let's say, any problem with your water work?
Like which type of problem do you want to ask?
I mean, any pain during the water work, any increase or reduction in the in your water, any water or urine?
No.
Okay, sir. Do you have any change in the color of your skin?
No.
Okay. Do you feel? Do you have any other bleeding from any other orifice of your body? I mean, from your mouth, with the cough, or with the water work?
No.
Did you travel recently, sir?
Yes.
Okay. Before how long and to where, if I ask?
I was traveling last time to India and Pakistan about almost 1 month back.
1 month back. Okay. For how many days you remained in the India and at which site, exact site
I was
within the
there
center?
in, yeah, I was there in central India and I was
Mhm.
there also in the central Pakistan and I stay in the both countries almost for 10 days.
Yes. Did you eat any food in the streets or did you go any
Yeah,
lakes?
of course, I love their street food.
Okay. Did you notice any change after the foods or any change in your symptoms after the visit?
Symptoms remained almost same.
Yes, sir. Sir, did you vaccinate yourself? Did you take the correct vaccines? before there, before
Yes.
yes. Okay, sir. So if I ask about your medical background, it comes also to my knowledge that you have high blood sugars and kidney problems. Can you just tell me about them? About the first of all about the high sugars. For how long you have the problem with the
I
diabetes?
was diagnosed being having high sugar levels, that is type 2 diabetes, about almost 18 years back. And
Yes.
then I developed kidney disease, and it happened almost, they were diagnosing me about 3 years back.
Yes, sir. Sorry for that. Sir, do you think that it is controlled? I mean, your last blood sugar check, HbA1c is how much?
Yeah, it is now in control. It is almost, it was almost 6.5 last time.
Very nice. What you receive, sir? What are the treatments? If you have a drug list, if you can show me.
Yes, I am taking something called loperamide off and on. I am
Okay.
taking a paracetamol, almost 2 tablets daily if I am having pain. I am taking a tacrolimus zero point 0.5 milligram twice daily. I am
Yeah.
taking something called prednisolone 10 milligrams daily.
Yes. Yes, sir. Thank you. If I ask, is there any change in the dose recently of any of these drugs?
No, as such.
Yeah, okay, sir. Did you have any side effects from any of these medications?
At least I am not aware.
Okay, sir. If I ask you why, if it comes to my notice that you take prednisolone and tacrolimus, can I ask why you take these medications?
Because they have done my transplant surgery.
Yes. So did you do the tummy surgery and it is kidney transplant?
It is a kidney transplant as well as pancreatic transplant.
Okay, sir. If I ask you, if you just tell me more about them, when you did these operations and before how
I
long?
have undergone these both procedures combined almost about 1 year
Mhm.
back.
1 year back. Okay, sir. So did you have any complications with the operation at that time?
At that time, it was a quite smooth recovery.
Okay, sir. Did you follow the pancreas function and the kidney function currently?
Yes, I am in the routine follow-up of my doctors, except that when I was visiting to Pakistan and India, I was out of the follow-up. Otherwise, I am a quite compliant patient.
Yes, sir. If I ask about do you have any pain at the site of the pancreas and the kidney?
Pain at that site of the surgery, no pain at all.
Okay, sir. Just before I go more about the urine, I have asked it. I've asked about the amount of the urine. You said that it is normal. Am I right?
I have not observed any changes there in the frequency or amount, and you are left with 2 minutes from now.
Okay, sir. Okay, I need now I need to ask about the some. Did you, sir? Where do you live?
I am living over there in my own flat.
You're a flat. Okay. So about do you smoke? Did you smoke?
I was smoking because these major transplant surgeries, but not now.
Okay, sir. So I have a few questions, but we may arrange it in the next time to ask from you. Just do you have if I ask about your concern and once I start to examine you. So if I ask about your concerns.
My concern is, do you think that I am going towards the failure of the transplant surgeries?
Okay, sir. So I appreciate your concern, and your concerns are quite valid. Now I need to examine you, and after the completion of the examination, and we may need to some tests, and I will have a better idea about the function of your kidney. For
Mm-hmm.
time being, I don't think that you have a problem with your kidney with the transplant functions. So I need to
Uh-huh.
now to start the examination, if I can, sir, because
Mm-hmm.
I may have any less time. So can I
Mm-hmm.
examine? Okay.
For sure, go ahead.
So, okay, I will, of course, the patient should be lie down at 45 degrees, and I will go to the end of the bed, and I need to
You
expose
are
the patient's.
going to the end of the bed and you are exposing the patient, and the findings are already there in front of you.
Okay, so there are scars and there are drain scars. There is central big abdominal middle laparotomy scar, and I don't see any other, let's say, abdominal swellings. Okay, and then I want to look, come to the hand, examination of the hand, and just look to the hand of the patient.
You are
Um,
looking keenly on the patient's hand, the nails, the dorsum, and keenly
yes,
acting like a sponge to gather maximum clues, and you are unable to
mm,
find any finding on the hands or nails, and your
very nice,
time is up.
very nice, sir. Very nice. Thank you, sir, and I will cover the patient.
Nice for ending of the time.
Yes,
Okay. So
very, a
we
nightmare.
need, yeah, no problem. We need a very good, crisp summary of your case with only positive findings.
Okay, sir. Mr. Zia, who is a 60 years old gentleman, came into us today with a complaint of a 3 month history of loose motions, okay, and diarrhea, watery diarrhea, on a background of abdominal pain. He's a noun case of the, let's say, diabetes, type 2 diabetes, and chronic kidney disease associated with, who underwent combined pancreatic and kidney transplant 1 year ago. On examination of the and he's on the, let's say, to not forget, he's on the drug medications, including the immunosuppressants prednisolone and tacrolimus, and
Mm-hmm.
diabetic anti-diabetic medications. On examination of the patient, I was able to examine on the observe or inspect the patient's abdomen, which there is, let's say, an
Uh-huh.
essential mid-laparotomy scar. It was old scar, no features of the infection or tenderness or redness in the scars. Okay, for this patient, I want to initially do some bedside tests, including the, let's say, bedside random blood sugars, examining with
No, no,
endoscopy.
we need a diagnosis, the list of differential diagnosis.
Okay, sir. My differential diagnosis for this patient, including first is the so first
Uh-huh.
is the um, inflammatory bowel diseases. I put ulcerative colitis and Crohn's disease. The patient's
Mm-hmm.
history for the 3 month history of, let's say, diarrhea, including
Mm-hmm.
two attacks of the bloody diarrhea, suggests that the
Mm-hmm.
patient is having any suggested for the history of the inflammatory bowel disease. I want to test for that later on.
Mm-hmm.
Okay, secondly,
My question is, when the patient is already having strong immunosuppressants with combined kidney and pancreatic transplantation, also the patient is on steroids. Do you think that the significance, the if there is IBD, it will be clinically significant?
okay, yes, you are right, sir. Because he's already on let's say, immunosuppressant. So yeah,
We are
it will go
dealing with
down.
a special category patient over there with a dual transplantation. So,
Yes.
what are the DDs coming in your mind?
So drug-induced and immunosuppressant-induced diarrhea. It's one of the. It comes to my mind actually, to be honest. Patients did
Which
a
type
pancreatic.
of immunosuppressants are linked with loose motions?
Okay, so mycophenolate mofetyl, I know exactly that leads to the diarrhea. Here in this case of the
Hmm.
patient, here in this case the patient is on, let's say, tacrolimus and prednisolone. By themselves,
Hmm.
they are immunosuppressants. They can make the patient prone to,
Okay.
let's say, infections. So,
So that's a good thing that we should be ruling out the immunosuppressant associated diarrhea. So,
yes,
but
sir.
I don't believe that it will be leading to the bleeding. This is quite concerning for us.
Yes, you are right. It will not lead to the bleeding, right, sir? Okay.
Hmm.
Actually, the bleeding and the diarrhea. What other comes to my mind? I've thought about the, let's say, CA colon, cancer colon, actually. uh,
Is there any
bleeding and
link of
blood
the
loss.
CA colon with the transplant surgeries?
Sir, immunosuppression after a while, after post-transplant, immunosuppression increases the risk of CA.
Uh-huh.
But it may need more time, but it increases the risk, sir.
Uh-huh. Okay,
Okay,
any other DDs?
any endocrinological diseases, I've thought about the Addison's disease. I've thought about the
Were you
because
asking
patients
about
have
any
it in.
pigmentation or any dizziness on standing from the sitting posture?
Yeah, right, sir. I'd asked about the skin changes, but I didn't ask about the posture actually. And you've said
Uh-huh.
that there is no skin change.
And
Yes.
again,
Uh,
the bleeding with the Addison disease is quite a rare thing.
Kyle Rearson. All right, sir. Okay.
Okay, so
Uh,
considering your top DDs, can you give us a thorough investigation plan for Mr. Zia?
Sir, initially I will send the general blood tests, general, including the complete blood count and looking for any anemia and any leukocytosis. I will send for the renal and liver function tests and considering the patient is previous renal transplant and
Why you are
let's say the
concerned about liver function test? Any logic behind?
okay, as a baseline test, and if I give any medication in the next few hours or next few days, I need to know about
Uh-huh.
the liver function test for anything.
Okay.
Serum electrolytes I sent in
Mm-hmm.
serum electrolytes, including the
Mm-hmm.
okay, serum electrolytes, inflammatory markers, CRP, ESR, and even we have an
Mm-hmm.
ESR, initial ESR here in this patient, which is seems to be raised ESR.
Mm-hmm.
Okay, after the that I will go for the HbA1c, checking for the HbA1c and blood levels of the drugs, tacrolimus and prednisolone in this patient.
So
And
do
then,
you think that this is quite a routine for us to check for prednisolone level in the blood?
no, sir, sorry, you're right, it's my mistake.
Uh-huh.
So, then next to search for some specific tests, including the according to the for example, I made the general stool exam, which is done here, general stool exam, fecal calprotectin, I made you, which is also done here, which is raised in this patient. Mm, I may do these stool PCR, maybe stool PCR.
PCR for what?
PCR, let's say for the viruses, viral PCR, CMV, for example, uh,
Mm-hmm.
CMV, CMV to be done. Okay, and
Mm-hmm.
I come to the after the bloods, I come to the imagings. Initially doing an abdominal ultrasound. I
Exactly
may
where do you want to see CMV? What can be the
CMV.
location of CMV?
Sorry, CMV. Actually, colitis. CMV colitis is one of
So what
the
is the
differential.
accurate testing for CMV colitis?
CMV colitis to colonoscopy. Can we do it by the colonoscopy and taking the sample?
Haha.
Okay,
What
and
else?
any colonoscopy, any imaging, one of the imaging after the ultrasound is to go for the colonoscopy,
Mm-hmm.
sigmoid colonoscopy, and looking for that and taking the sample. Inside the stool, I have stool, let's say, stool PCR. I can do stool PCR and looking for the CMV, sir. And we said that colonoscopy, and I may
We
go
need
for
a
to,
quite holistic plan for this patient because this patient is posing quite a challenge for us. Regarding a
yes,
dual transplant, we are quite concerned about a lot of things with the comorbidities and this new challenge of the loose motions. So, can we have a
yes,
very good holistic plan for this patient so that we should not be missing any underneath diagnosis also?
nice, yes. Um, Yes, you are right, sir. As we said that in the blood, initial general bloods, and about the pancreatic function, I can do serum amylase and serum lipase.
Uh
The
huh.
renal function, as we mentioned, as a routine test to be done.
Uh huh.
Uh, mm,
And we're
uh,
getting the idea over there that the renal functions are slightly deranged.
yes, sir.
Uh huh.
So the causes of the So the causes of the deranged renal function in this patient, we have already there is a loose motion. This can be explained by this, or possibility of let's say rejection, acute let's say acute kidney rejection.
How
Uh,
and when we will be suspecting that my patient is going into rejection of the kidney?
Okay, so there is as you mentioned that there is a raised renal function. First of all, the time frame. Actually, in the first 6 months, acute rejection
Mm-hmm.
occurs. In the first 6 months,
Mm-hmm.
and this patient is a bit late. It's more than 1 year actually after that.
Mm-hmm.
So there is a reduced possibility, but still can be. Or acute rejection. We said that the renal function,
Mm-hmm.
deteriorating renal function.
Mm-hmm.
May do an ultrasound. Ultrasound can be helpful with that also. Uh,
Mm-hmm.
Other cause of the deteriorated renal function could be an infection, a viral infection, such as we have, as we said, CMV
Okay, so
can be.
can you please, based on your DDs, can you formulate a good holistic management plan for your patient?
Okay, sir. In this patient, as you have now mentioned that, sir, but can I see the vital signs before anything, sir? I want to see
For
the
sure,
observation,
you
the vital signs.
can. You can. And the screen is already there in front of you. Have a look, please.
Sure, thank you.
Welcome.
Okay, so pulse 100 beats, blood pressure is 100 over 18, ESR 60, stool samples few. Sir, I want to first admit this case to the hospital for the investigations, and as we said that he may need IV fluids before anything, and there is a deterioration of the renal function. Already the patient is concerned about the function of his transplant, so that we may need to do a bit to complete the investigation so that we can reassure the patient. We want to admit the patient to the hospital, okay, and start a multidisciplinary team approach, including the renal, the nephrologist, and the uh, possibly endocrinologist. Okay, we're starting the IV fluids to the patient. Okay,
Mm-hmm.
and then. Uh, as we said, accordingly, initially supportive care. This forms the IV fluids and doing the blood investigations, as we have mentioned, sending the stool
No,
sample for the
right
PCR.
now we are quite concerned about the treatment.
Yes. Initially, sir, as long as the etiology is not clear, we're just giving the fluids, and the patient, if he is in pain, we can give the appropriate painkillers to the patient, and the
Say, for
painkillers.
example, despite of your routine investigations, which you are mentioning, they are coming out to be normal, and there is a lymphadenopathy in the neck. So, how you will approach this case?
Yes, sir. Lymphadenopathy with the diarrhea and bloody diarrhea. We may need we have to think of the etiologies, such as a tuberculosis, for example, or
Say,
lymphoma,
for
for
example,
example.
all TB tests are coming out to be normal, and how to
Nice, sir.
approach this lymphadenopathy.
Yes, sir, I will do an ultrasound for the lymph node to see the exact, let's say, first of all, we do initial examination, general examination of the lymph nodes, including the spleen, in order to know the exact destination of the lymphadenopathy. For example,
Say,
it's
for
only in the
example,
neck.
there is hepatosplenomegaly over there in the tummy.
Okay, so there's a possibility of post-transplant lymphoma here in this case. So,
And what can be the etiology over there and how you will be managing this?
sir, the post-transplant lymphoma is it is more in this case, in according to this case, most probably it's due to the immunosuppression actually here in this patient.
And which
So
immunosuppressant is quite culprit in this case?
in this case, you have tacrolimus, sir. Prednisone and tacrolimus. I
Okay.
will give yes, the tacrolimus. Again, I will sum up the hematology team, okay, and the oncology team, the oncology doctors, hematology doctors, and initially we may do an ultrasound of the neck and the abdomen. We may progress to the CT chest, CT neck, chest, and the abdomen to search for for staging of the lymphoma and exact site of the
Uh-huh.
lymphoma. We may need to go
Mm.
to a biopsy, lymph node biopsy, in order to confirm the diagnosis of the lymphoma. And in accordance with the oncology team, we may decide about the further management of the condition,
Mm-hmm.
which may include the
Mm-hmm.
chemotherapy or
Mm-hmm.
radiotherapy, and
Okay.
rearrangement of the next, let's say, immunosuppression.
Uh-huh.
Okay, so
Okay, so let's start having discussion on this case.
thank you, sir.
And we are having this case ahead, and let's explore it and let's see what are the learning points today. Because I promised that inshallah we'll be covering maximum cases from this one approach, and this case, the case we are discussing right now, is sometimes posing quite challenges for our candidates in the exams. So before we are going ahead, let's see exactly what information we are getting from outside. Just give me a second. So, Dr. Gailan, please keep your mic unmuted so that you should be staying in touch with me, okay?
Okay, sir.
So, the issue list, first of all, I want to make the issue list in this case. For me, the issue list, number one, of course, is abdominal pain. Second thing is loose emotions. Third thing is patient is a known case of number one DM and number two CKD. Now they are also mentioning surgery, the significant history of abdominal surgery. And they are not giving me any idea exactly which sort of surgery we are dealing over there. And when I am seeing, likely I am feeling that in the labs, our gut is inflamed, as evidenced by some few pus cells in the stools, with stool for colprotactin being positive and ESR on the higher side. Are you with us?
Yes, sir.
My voice is clear to you?
Yes, sir.
Okay. So now the challenge in this case. For me, the first challenge which is posing for me in this case is why this patient is getting loose motions and abdominal pain. Second challenge for me is exactly what is the state of diabetes right now, and if the patient is not diabetic right now, what are the complications I am dealing with this case? Because likely this patient has already undergone renal transplantation secondarily to diabetic nephropathy, so I am quite concerned about the other damages also. Third challenge which this case is posing to me is the condition of dual transplantation. I am dealing with two transplant, that is pancreatic and kidney transplant. So I am concerned about whether these two transplants are working well or not. Another challenge for me in this case, the hidden challenge is that whether I am getting any side effects or any adverse effects of immunosuppressants or not. So it constitutes a complete clinical consultation for this case, because this is a special population we are dealing right now, that is the patient is a transplant patient. Are you getting me?
Yes, sir.
So, how to approach this case and how to be very smooth in this case? First of all, for me, what I will be doing is that I am starting, of course, in a way that I am taking my presenting complaints. Even before starting the presenting complaint, I am seeing something in the given data that my patient has a significant abdominal surgery history. Of course, the patient will be telling me, he will not be hiding from me. So my approach will be that I should be asking in a very start, hello sir, good morning. My name is Dr. SM, one of the doctor in the clinic today. We are over here to take a medical history and examine you if this is okay with you, okay with me. During this process, might be I'm taking few notes and I will be reassuring you that they will stay confidential with me. This is a journal protocol we are following before any sort of clinical consultation. Now we are going ahead in a way that I will be asking first that I am seeing in your medical record that you have undergone some sort of tummy surgery. So can you please tell me more about it? Or if you are not comfortable asking it in a very start, try to ask it in first couple of minutes. Are you getting me? Hello?
Yes, sir. Yes, sir. Yes, sir. Yes.
Okay, so that you should not be getting any surprise at 12 or 13 minutes. So if there is anything which is not clear in the given data, not only in the clinical communication, not only in the clinical consultation, but also in the clinical communication, we should be immediately asking to our patient. This is the rule of for the PACES. Now you're asking, and he's telling you that I have undergone combined renal and pancreatic transplantation. Only one question I will be asking over there exactly when it has happened. It happened about 1 year back. So I am not now going in the details of it. Immediately, I am starting from my history taking. For me, there are two presenting complaints. Number one is loose motions, and number two is abdominal pain. So let's first start from the loose motions. Remember that chronic diarrhea is a symptom if we are not approaching it very well. It can land up in the failure. Why? Because the loose motions, the chronic diarrhea is having multiple causes. And when a symptom is having multiple causes, and if our history taking is not quite strong, we can land up in the complications. So I am today teaching you people the approach for the chronic diarrhea, how to approach it very well. You should be very strong, you should have a very good grip on the chronic diarrhea. And I believe that if your history is very good, inshallah, you will be able to reach your diagnosis max in 5 or 6 initial minutes. So whenever you are dealing with a chronic diarrhea, what should be the approach? So first thing we are dealing over there is to go ahead towards OD para. Onset, gradual or sudden, duration 3 months, progression. So initially if the patient is having 2 or 3 episodes right now, what is the situation? Then aggravating factor. In the aggravating factor, I will be asking everything which I can ask, like any stressors, like any changes in the environment, like any worsening with roti, chapati, pizza, pasta, bread, or milk products. I will be asking also about the relieving factor, specifically any fasting state or any sort of any changes in the environment, and also any medications. Mr. Guide, my voice is getting a lot to people.
Yes, sir.
Good. Now, second challenge is this last A. This last A is quite important. That is associated symptoms. Okay, now we are dissecting the all causes of chronic diarrhea. So first thing we need to go ahead over there is to separate it between large bowel type diarrhea and the small bowel type diarrhea. The people who have already attended my sessions and my courses, this will be repetition for them. So don't worry, it will be just refining the things in your mind. So first of all is over there, I am writing for you people, small bowel, and there I am writing for you people, large bowel. So the small bowel type diarrhea is of course large in amount. Why? because the malabsorption is creating quite a large volume of the stool. Large bowel type diarrhea is small in amount because already all food products have been already digested sorry till terminal ileum. So if the pathology is there in the large gut, we will be getting small amount of diarrhea. Second is the content. Small bowel usually having problem with the malabsorption. So I will be getting steatorrhea, might be plus minus, and it will be absent over there. Over there, I can get food particles, and over there, I will be getting watery diarrhea or watery content. Are you with me?
Yes, sir.
Then small bowel type diarrhea usually is painless because the malabsorption is painless. But large bowel type diarrhea is usually the tumors, the cancers, then the colitis, then the all sort of IBDs. So it is usually painful. I am not saying that this is exact discretion, but I am dividing it to have a clue because ultimately we need to plan for the scopy. Should we approach the gut from the below or should we approach the gut from the above? It is very important. And the pathologies are totally different between the upper gut and the lower gut. Now, getting back, small bowel type diarrhea will not have any tenesmus, but there will be tenesmus. Tenesmus is happening when the patient is having proctitis. That is the inflammation in the rectum. So, inflammation is teasing the rectal valve and giving the sensation to the patient that you have to pass the loose motion now. So, he's going in the toilet, sitting over there. The sensation to pass the loose motion is there, but it is not coming. So this is tenesmus. So you can ask the patient that do you feel the sense of incomplete evacuation after your each bowel movement? So tenesmus is again giving you a clue that you are dealing with a sort of large bowel type diarrhea. Again, no bleeding, usually no bleeding in the malabsorption, but there we can get bleeding. So these are the discretions between two type of diarrheas. Lot of time, 80%, 90% conditions, the lower bowel, that is a large bowel pathologies are different and small bowel pathologies are different. So if you are taking your history in this fashion, inshallah, you will be able to pinpoint the location exactly where is the diarrhea. Now, some conditions, like say for example lymphoma, like say for example Crohn disease, they can involve any portion of the bowel. So you can get mixed picture also. So don't get terrified. At least your history is quite complete. At least you are asking all the questions to show to your examiner that I am a safe doctor. Dr. Gail, now I say a lot to people.
Yes, sir. It's clear.
Good. Now, after that, we are seeing exactly in which direction my case is going. Now, before we are going further, if the chronic diarrhea is the presenting complaint, for me, the next challenge will be if I am dealing with small bowel type diarrhea, I am quite concerned to ask its complications. So, what are the complications of small bowel type diarrhea? For me, I will be quite concerned about hair loss, vitamin A and zinc deficiency, night blindness, dryness of eyes and skin, again vitamin A deficiency. I'm concerned about oral sores, vitamin B deficiency, chelosis, Chelosis are the sores around the, what you say, your oral cavity, like angular stomatitis, again zinc deficiency. Then, for me, the quite concerning the thing is, sorry, is history of fractures. Why? Because it can lead to brittle bones, vitamin D deficiency. I'm quite concerned about the history of the bruises. Why? Because of the vitamin K deficiency. Are you getting me?
Yes, sir.
And if you are taking this history in this fashion, you started from Odipara, then you are going for the differentiation between small bowel type diarrhea and the large bowel type diarrhea. Then you are going towards these complications. I don't believe that it will be taking more than your 2 minutes and 30 seconds or 3 minutes, because these questions are quite a checklist questions, and you are just asking, and the patient is saying to you yes or no. So, do you have any hair loss? Any difficulty seeing at night, any dryness of eyes or skin, any oral sores, any sores around your lips, ever you got any fractures, ever you got any bruises. It will not take much time. So you are screening basically the complications of malabsorptions also, only in the cases of small bowel type diarrhea. Now, after that, we have completed it. But for me, the concerning thing over there is the diarrhea can be, of multiple types. And we need to separate it. And each and every diarrhea is having its own questions. So let's discuss them in detail. So first thing which we are discussing over there is, are you getting up from sleep to pass the loose motions or not? So if the patient is getting up from the sleep to pass a loose motion, it means that the diarrhea is organic. The pathology is organic. But if he is not getting up from the sleep or she is not getting from the sleep, it means that this is brain gut dysfunction, likely irritable bowel syndrome. Clear?
Yes, sir.
Good. So another type of diarrhea is celiac disease. We have already discussed it in our history taking for roti, chapati, pizza, pasta, bread. We are quite concerned about weather preferences because of your friend hyperthyroidism. I'm quite concerned, sir. Do you have any pigmentation or darkening of the skin anywhere for Addison disease? I am quite concerned also about IBD. For the IBD, the questions are ever, not right now, ever. Ever means it is also covering the immediate past history. Ever you got any red eyes, oral sores, backache, specifically low back ache or stiffness, any non healing sores anywhere in the body, any rash anywhere? Of course, we have already asked about the fever and abdominal pain. Now, why it is relevant? Uveitis associated with IBD, oral sores, it is quite common in Crohn's, but remember that on the basis of oral sores, don't say that it cannot be ulcerative colitis. Sometimes the oral sores are also present in ulcerative colitis also. Then when you are talking about low back ache or stiffness, it is showing that you are excluding sacroiliitis. The non-healing sores, which we are in the common, word saying beggar's ulcer, that is your friend pyoderma gangrenosum, quite a chronic ulcer with autoimmune etiology. Then erythema nodosum, this is the rash, quite painful on the shins. Okay.
Okay, sir.
So these are the common questions to be asked in the diarrhea to make sure yourself that you are going in the right direction. Before we are ending up this topic of diarrhea, before we are concluding this topic of diarrhea, I want to ask you a question. Question is that what do you think that it can be linked with the chronic diarrhea? That is, the patient is having history of 3 months and the patient is having diarrhea and it is not resolving, and this diarrhea is quite organic. So now think out of the box. Specifically, if you are getting the history of the weight loss. Again, the history of weight loss depends upon exactly is it significant or not significant. Say for example, the patient is saying to you that I am having weight loss of 2 kilograms over 1 year. It is not quite significant. If same patient is saying that I am having weight loss of 6 months, sorry, 6 kilograms over 3 months, it is quite significant. Secondly, whenever you are dealing with weight loss, we should be quite concerned that this weight loss is intentional or unintentional. So, patient is having weight loss, patient is having chronic diarrhea, and in the history, you are able to elicit that there is some sort of bleeding also, 2 or 3 episode, and abdominal pain. So, what it can be or what I should be bothered about? For me, I need to rule out two things. Number one is tuberculosis, TB enteritis, and number two is lymphoma. Now, of course, I can appreciate this fact that exam is quite a stressful condition. And sometimes in the exam, we are unable to focus on the history quite clearly. And it is only happening if, say, for example, we are not planning ahead exactly in which direction I will be moving. But say, for example, you are in stress and you are not able to follow this approach. Even you are having the bullets in your hand. So, what are the bullets? I am always telling you, and I am always teaching you people in the courses also, that these questions are always the bullets. So deliberately right now, for the teaching purpose, if you are appearing in the exam immediately after the loose motions, you will be going ahead towards the abdominal pain. But for the teaching purpose, I am right now skipping the presenting complaint of abdominal pain. I am coming towards the journal questions. Now, journal questions are always the bullets in your pocket, and they are always ruling in and ruling out a lot of DDs. So, bullets are number one, if you are skipping something, fever, these are journal questions, weight changes, gain and loss, rash spots, and pigmentation, weather preferences, sweating, shakiness, not tremors, shakiness, diet, appetite, and sleep, sweatings, and another thing is fatigue. What I'm missing a highly important question, that is, sorry, that is lumps and bumps, that is lymphadenopathy. So the technique over there is a lot of candidates are complaining that sometimes we are unable to complete the history in the 9 minutes. So it is happening when you are doing a repetition of the questions. So the questions which I have already asked, I will not be repeating them. Say for example, fever already asked, weight changes already asked, rash spots pigmentation already asked, weather preferences even already asked in the history of loose motion. Sweatings, I'm not asking, I will ask now. Tremors, I will not asking, I will ask now. Diet, appetite, sleep, I can ask. Sweating, fatigue, lumps and bumps. So what I am getting in this history, that addition to those symptoms which I was already asking with the history of loose motions, that I am also getting sweatings, fatigue, lumps and bumps. And Dr. Gallen, you were not asking about lumps and bumps.
Yeah, right, sir. Yes, I've missed it.
Yeah. So
Very
again,
important.
I am summarizing the case. Chronic diarrhea, off and on bleeding, with 6 kilogram of weight loss over 3 months, mixed type of diarrhea, and my patient is having mucus there. My patient is having weight loss, lumps and bumps, fatigue, sweating, low grade fever. So picture is now getting more clear to me. For me, right now, I am more concerned about lymphomas. I am more concerned about TB. Are you getting me?
Yes, sir.
So, my aim is that my students should be able to reach diagnosis at maximum 7 or 8 minutes, maximum. And my candidate should be able to bring out top three differentials based on the history only. For me, my candidates should just enjoy the examination further. So if you are able to touch the diagnosis at 6 or 7 minutes, clinical consultation will be really easy for you. So for me right now, considering this history, I am considering number one, lymphoma, number two, TB, number three, think whatever you want to think. But two DDs should be at top even regardless of the transplant. Yes, considering the transplant, because it's a special group, lot of things are popping up in my mind. Might be CMV colitis, might be cryptococcus, might be some infection, might be even HIV. But again, to label this patient as having HIV, I am already having the social history in which I will be exploring the sexual history and drug history, IV drug. Clear?
Yes, sir.
Good. Now, getting back to this case, what we are missing. So we are missing an important presenting complaint that is abdominal pain. So abdominal pain history, the pain history is quite simple. For if you are having any pain, not only abdominal pain, any pain, my candidate should immediately turn the attention towards the Socrates. And my candidate will not move forward until he or she has completed the Socrate. And these are checklist questions only. Exact site, that is that say to patient to touch that area, touch, pinpoint it. Then onset, sudden or gradual. Character, you are confused slightly in the character trigyland. Character means that how it feels like. The pattern of the pain is something else, that it is intermittent or continuous. The
Yes.
character feels like sharp, pricking, stabbing, dull boring, gripping. So each and every character of the pain is having its own DDs. Like say for example, the patient is having crushing pain. For me, MI will come on the top with the chest pain, with the upper abdominal pain. Patient is having colicky pain means that coming like that in the layers. So for me, it is a hollow organ pain, like say for example, from the gallbladder or the stomach or might be gut.
Yes.
Dull boring pain, of course, it can be any visceral pain, say for example, liver. Sharp stabbing pain, for me, I will be thinking about pancreatitis. Okay.
Yes.
Now,
Nice.
site onset character radiation. Radiation is again very important. If going to shoulder, might be gallstone. If say for example going to back, might be pancreatitis. If say for example upper abdominal pain is going towards the arm, I will be quite concerned about MI or angina also. Associated symptoms. This A is associated symptoms. I am skipping for few seconds for the teaching purpose. Then timing, any specific timing of the pain. Then exacerbating relieving factor E. It is very important. So in the exacerbating factor, I am giving the option to the patient. Say, for example, any posture is making it bad. Say, for example, exertion is making it bad. Say, for example, any food is making it bad. Because each and every question is having its own significance.
Yeah.
Gastric ulcer pain is more bad with the food. Duodenal ulcer pain is more bad in the empty stomach. Pancreatitis pain or gallstone pain might be more bad with the food, especially fatty food. Postural pain can get bad or good. Pancreatitis, bad pain with lying flat and improving with the bending forward. Exertional pain might be linked with the heart. Are you getting me?
Yes, sir.
So instead of asking a general question to the patient that anything which is aggravating or relieving it, better thing is that you should be giving some option to the patient. Then severity. Again, severity is something which is very important. If the patient is having pain out of 9 out of 10, so I am concerned about AIP, acute intermittent porphyria. I'm concerned about pancreatitis. I'm concerned about gallstone. If, say, for example, patient is having pain, might be 5 or 6, so I will be considering a light pathology like functional dyspepsia, like gastritis. Okay,
Yes.
so the pain history should be holistic. If you are taking this history in this fashion, not only to take the history, rather you are asking the question to reach a diagnosis, inshallah, I believe that you people will be able to reach diagnosis maximum in 6 or 7 minutes, not more than that. And of course, if you are reaching diagnosis at 6 or 7 minutes, so you will be able to have a good grip and targeted approach on the examination. So in the summary right now, what I am getting that my patient is a diagnosed case of CKD with type 2 diabetes, and diabetes is for about last 15 to 20 years. CKD is for about last 3 or 4 years, had undergone combined liver pancreatic and kidney transplantation, presented to me with the history of abdominal pain and loose motions for about last 3 months. Loose motions are associated with often on bleeding, with the significant weight loss, fatigue, lymphadenopathy, sweating, and low grade fever. Patient is also complaining alongside this loose motion that I am having tummy pain, which is mild to moderate in intensity, dull, boring in character, center in origin, and is having no other associations, including radiation. Clear?
Yes.
Again, I was able to make my DD of TB and lymphoma based on the history of loose motion. So this thing is now strengthening my DDs that yeah, my case is going towards this direction. Now, the next step, of course, before we are winding up this discussion, even during the real exam, we should be asking ourselves that in which system I am playing. Is it nephrology? Is this a neurology? Is this urology? Is this endocrinology? For me, this is gastroenterology. So I am completing the gastroenterology questions before I am winding up this discussion. Any history of jaundice, any difficulty letting food down, any bleeding, any bleeding in the vomitus, or any dark or black stools. Now, chapter close. I'm locking over there. But there are few considerations to go ahead with this special population. For me, I am now jumping towards the past history. In the past history, I am dealing with four things. Number one, kidney transplantation. Number two, pancreatic transplantation. Number three, diabetes. And number four, CKD. Now, number one thing is we should be going to them step by step. So, for the past history, you are having diabetes for 15 years. So now I am asking you a checklist questions. Please just reply in yes or no. Because now this patient has undergone combined renal and pancreatic transplantation. So likely he is also having some other complications also. So ask about any blurring of the vision. Ever you got any stroke or any weakness anywhere in the body? Ever you got any sharp chest pain, any pain on walking, that is peripheral arterial disease, any increase or decrease in waterworks with the foam there, CKD, anybody is telling you that you are getting pale than before, CKD, and ultimate is your peripheral neuropathy. CKD has already been diagnosed previously, but right now this patient had undergone kidney transplantation. Second thing to bother some over there is pancreatic transplantation. So I will be asking about any steatorrhea. I'll be asking about any sort of any high sugar levels if you are monitoring them, any fevers, high grade fevers. So these questions are linked with the failure of the what you say pancreatic
Pancreas.
transplantation. Are you getting me? My voice is get to you?
Yes, sir.
So what are the features? Repeat for me.
Okay, so in the pancreas and in the kidney transplant, the kidney
No, no,
transplants,
we are only right now concerned about pancreatic transplantation.
yes, sir. You said that you have to ask about any steatorrhea, malabsorptive symptom, any high blood sugars recently. Okay, these are the
Like that is
symptoms of it.
hyperglycemia.
Yes, high blood sugar.
So basically, the patient will be having the same symptoms which he was having previously. Number one is hyperglycemia. Number two, the patient can have bad abdominal pain and tenderness, just like you were getting in the pancreatitis. Then, of course, if it is early transplantation, we can even get the thrombosis over there. So complication we'll be discussing later on. This is a separate topic. Now, the second thing is renal transplantation. So for the renal transplantation, unconsciously, we have already asked about the waterworks, and it will be clarifying to us that this patient is having good functioning of the renal transplantation. No decrease in output, no decrease in amount, no decrease, no any foam there, nothing over there. Now, the complications I'll be coming back later on. Now, the family history I should be checking, family history of any loose motion, family history of any contact with the TB person, family history of any cancers, family history of any problem in the bowels. Very important. Then, social history. The social history we are concerned about. Sajid loves tea. As for smoking, current and past. A for alcohol, current and past. J for job, I for illicit drug. D for driving, T for traveling. Now, two things are coming in as posing a challenge to us. Number one is IV drug abuse history. Number two is any sexual history, because of course I need to rule out HIV also, because the patient is already on immunosuppressants. So if the patient, you are taking the history of any illicit or party drugs, so ask the two questions, because some people are thinking illicit drugs as, they are considering them illicit, but some people are not taking them illicit, they are taking it as just a party drugs. So ask, do you have any history of party drugs, illicit drugs? Number one. Number two, if yes, so are you doing needle sharing or not? If yes, so are you sorry. Number one, are you doing any illicit, using any illicit or party drugs? Number one. Number two, if yes, which drug? Number three, through which route? Number four, if IV route, so are you doing needle sharing or not? Then, of course, sexual history, sexual contacts history outside marriage will be very, very important over there also. Because if you are putting forth a diagnosis of AIDS, so examiners cross questioning will be that what are the risk factors over there. Remember that acute HIV and AIDS, these are two different entities. Acute HIV usually presenting also with the loose motions, with the lumps and bumps, with the sore throat, with the fever. So this diarrhea or loose motion in acute HIV is because of HIV infection. But when you are dealing towards the AIDS means that now the HIV has taken over the control of your complete immune machinery. So as the patient is now immunosuppressed, all the diseases, sorry, all the infections will be attacking on the patients. So candidates, these are the very common mistake in our courses, that our candidates are sometimes confused between acute HIV and AIDS. Acute HIV is a separate thing, AIDS is a separate thing. Clear?
Yes, sir.
Good. Now,
Yes.
last thing is we have covered loose motion, the issue list, remember it. We have covered abdominal pain. We have covered whether this pancreatic transplant is working well or not by asking about severe abdominal pain, steatorrhea, any ever you got any hyperglycemia. If you want to beautify your history, you can ask about polydipsia, polyphagia, polyuria. Then we are bothered also about renal transplantation on the basis of history only. We are not concerned right now about the investigations, we are taking the history. After that, when we have completed our history, it's time to go towards the examination. My candidate, before they are planning for the examination, we will never be going randomly. We will have a plan in the back of our mind that exactly what I am anticipating in this case and how I will be catching the diagnosis. For me, right now, the main challenge over there is exact etiology of loose motion abdominal pain. For me, TB is coming ahead. For me, lymphoma is coming ahead. For me, HIV or AIDS is coming ahead. Second challenge for me that is this patient is having a healthy transplantation. Everything is going smooth and fine. The third challenge over there for me is, am I dealing with any complications or not? If you are missing any history in this history taking scheme, so you can ask it in the examination. But my suggestion is that try to complete your history before you're embarking on the journey of the examination. Clear?
Yes, sir.
Good. Now, let's go ahead and it's time to move towards examination. So tell me, uh, just a second. Okay, sorry, I'm back. Now, for me, uh, the challenge in the examination, let's go ahead towards the examination also. So over there, we are going ahead towards systemically good examination to save our time. So first thing, Dr. Gailan, we will be asking from the examiner that I want a recent observation charts, recent vital sheets. We don't know that these vitals are current or not. Second challenge, of course, is to look for our exact diagnosis. So first thing, palpate lymph nodes, examine eyes for uveitis, any sluggish pupillary reflex, red eyes, anemia. Then we are going towards oral examination. Might be we are getting any rash over there, any cheilosis. Then we are going towards clubbing. Then we are putting, we are having an idea for examining for what you say the shins for any rash or any sores over there. So this examination will not take much time. I am deliberately not going right now towards the abdomen examination because I know that if I am touching abdomen, I need to cover kidney, I need to cover pancreas, I need to cover also, of course, examination for chronic diarrhea. Dr. Gail, my voice can allow to people?
Yes, sir.
Okay. Just a second, just a second. Okay, sorry, I'm back. Now,
Yes, sir.
abdominal examination. Take it as a normal abdomen. Don't get terrified. Do your abdominal examination as you're doing. Go to the foot and see if you're finding anything. So, we are getting in abdominal examination. This is the abdomen. We are getting a midline scar, that is laparotomy scar, right?
Yes, sir.
They are using this scar for combined kidney and pancreatic transplantation. And let me confirm one thing for you people, that they are putting both organs quite superficially. So you can feel them if possible. You can palpate them. If you are getting only the solo renal transplantation, so you'll be getting scar like that. This scar is something called Rutherford Morrison scar. Sometimes with these what you say scars, you can get another scar. This scar I am showing right now, the interior surface of the trunk. This scar can be there outside, that is posterior lateral surface. I'm using the word posterior lateral aspect of the trunk, that is a nephrectomy scar. And they are sometime making, rather I should be drawing it over there, sorry. This can be, they are making it for to make the bed for the transplanted kidney. Other scars might be you are getting peritoneal catheter scars, multiple scars on the tummy. Are you getting me?
Yes.
So we should have these things in our mind before we are even touching the patient. So we are examining inspection, then palpation. So in the palpation, in the inspection, we are getting all these scars or plus minus scars. In the palpation, first thing is superficial palpation, and warn the patient that I am about to palpate your tummy, touching your tummy. So ask first, do you have any pain anywhere? Even if you feel any pain during my examination, immediately let me know. So you are doing superficial palpation in the S-shaped fashion, then you are doing a deep palpation, and it will be quite a mistake not seeing on the patient face when you are doing a deep palpation. Why? You are doing deep palpation, patient is having pain, he is controlling pain, making faces on you. Of course, you will lose marks in patient welfare. So, in the deep palpation and visceral palpation, make it a habit that you are always looking towards the patient face. So, when you are dealing with deep palpation, my question is what I will be anticipating if this is a case of TB enteritis or if this is a case of lymphoma. Can you guide me, please?
Sir, and you mean on examination of the abdomen, what would be the features if we see in case of the
Yes,
TB?
in case of
Okay,
TB, in case of lymphoma.
yes. Sure, again, we do the superficial and deep palpation, and we are searching, of course, for the tenderness before anything and masses.
So, two things
Usually,
I
we,
can get:
yes,
mass
yes,
or tenderness. Clear?
yes, yes,
Remember that the common site of the mass of your friend TB or Crohn disease is this site, ileocecal valve, that is right iliac fossa. And this is really not an uncommon finding in the cases of Crohn's or TB enteritis. Ileocecal junction is quite a favorite place for TB and Crohn disease to attack, and they are usually having a mass over there. Look for it. And again, if you're getting a mass over there, the DDs will come forth. That is, might be this is a case of Crohn's or TB, or might be some massive type of appendicitis. Usually, appendicitis retro, like it is before the retro to the colon, and might be there is some mass linked with if she's a female with fallopian tubes. But I'm quite concerned right now about TB enteritis or, say, for example, Crohn. Then, when you are dealing with the lymphoma, you can get a mass anywhere. So, what are your other anticipation in the examination of this patient?
Uh, you mean about the this case, sir? About the and if we want to look for any organomegalies, if there is
Yes,
any
I
splenomegaly.
can get I can get your friend liver.
Yes,
Okay,
yes,
liver can be enlarged. I can get spleen.
yes,
So this is my anticipation, even without touching the, even without before even examining the patient. I can get these findings. Completed. Another thing
yes,
which I am bothered to check, remember what I am missing. Ascites,
yes,
exudative, shifting dullness. Clear?
yes,
Now, going towards kidney examination, no rocket science in it, simply palpate over it, and you will be getting a superficially situated mass, and this mass will be of your palm size. It is quite evident, and you will just palpate it. It is like your palm size, a normal transplanted kidney. In the pancreas, sometime if the patient, the wall is quite thin, the abdominal wall, you can get a linear mass over there, and sometime you are not getting it. So depending upon the patient wall, you can get a mass, and sometimes you are not getting a mass in the case of pancreatic transplantation. Now, if you are getting a mass in the right iliac fossa, which is not of your palm size in the exam, it is a quine size. So this is still a transplanted kidney, but unfortunately, it has been fibrosed now, and this is a failed transplant. Now you can check for pedal edema. And the last is to check for the bruit. Say, for example, this is the umbilicus. So I will be concerned to check the bruit not only on the pancreas, but also on the transplanted kidney, because sometimes these patients do have complication as aneurysm. Before winding up this case, if the time is there, good. If no time is there, no problem. Say to your examiner that, sir, I would like to complete my examination by checking for peripheral neuropathy. And if the patient was complaining to you of the blurring of the vision, you can say that I would like to complete my examination by doing fundoscopy and, of course, vision testing. Clear?
yes, sir.
Alongside peripheral pulses. So over there, we have completed our history and examination. Travel history was slightly deficient. Travel history is important when we are discussing the case of the travel history. Travel history, the recent travel is not as much important as the travel history before the onset of the symptom is important. If the patient is having travel history, recently, 15 days back, 1 month back, it is not important. The important thing is any travel history before the onset of these symptoms. Again, where he was traveling, which sort of tour was that, hotel food or street food, bottled water or tap water? Were you completing your prophylaxis for malaria and others or not? Whether you were completing your vaccination or not? Any contact with the sick person over there or not? Dr. Galen, everything is clear?
Nice, sir. Yes.
Good. Going towards our DDs, for me, the DD, of course, is lymphoma, likely because of tacrolimus. And one thing was skipped during my presentation is the drug history. In the drug history, the important components are, can you please show me your medication list? Number two, are you compliant with this list? Number three, any other medication other than this list, which also include OTC medicine and herbal preparation. Then any start of any new medication before onset of these symptoms, any stoppage of any medication before onset of these symptoms, any side effect if you are experiencing of these medication. Last is I am bothered about the culprit medication, that is tacrolimus, that since how long he is taking tacrolimus. Clear?
Yes, sir.
Good. Now our investigation plan. Investigation plan, of course, we should have a plan in our mind how to approach this case. CBC, ESR, CRP, stool detailed report, stool for calprotectin or lactoferrin because it will be showing your gut inflammation. Then stool cultures. Then of course we will be bothered about lymph nodes FNAC. We will be bothered about lymph node excision biopsy if it is non-conclusive. That is your what you say your FNAC. Then of course one X-ray is required, and if there is any suspicion the X-ray, I will not be hesitating to go towards the CT scan with the contrast of the chest also, depending upon the renal functions. CT abdomen is very important with the contrast, and I am locating exactly where is the lymphoma. If the lymphoma is there in the upper gut, I am going for upper GI endoscopy. If it is there in the lower gut, I am going for colonoscopy. Usually the location is in the upper gut, ileum. Then I will be not hesitating to take the biopsy, and if it is outside and the reach of endoscope, so I can also employ endoscopic ultrasound guided transmural biopsy. Clear?
Yes, sir.
Good. TB testing, routine TB testing, gene export. I am telling to my examiner, I am bothered to screen for HIV, of course, tacrolimus level, and I am looking for the routine testing, the routine monitoring for the transplants. Serum lipase, serum amylase, liver function tests, HbA1c, and monitoring for the sugar levels for pancreatic transplantation, calcium levels. For renal, I am looking for urine detailed report, urine for microalbuminuria. I am looking for renal function test. I am evaluating it exactly which sort of renal insult is that. If there is any suspicion of rejection, rejection can be of three types. Inshallah, I'll be discussing it later on. Hyperacute, acute, and chronic rejection. We will not be hesitating to take the biopsy from the viscera. Is it clear?
Yes, sir.
So we should be preparing ourselves for any possible question in the viva. Now, getting back to the management. So management first is non-pharmacological. So can you formulate a non-pharmacological plan for this patient, Regilan?
Yes, sir. As we said, first of all, it should be MDT approach and the multidisciplinary team. We need to, of course, later on education of the patient about the transplant and about the drugs and features of the rejection, about the diarrhea, how to rehydrate until it come to us, and about the social care for the patients, and if if he stopped or quitted the job, occupational care, as we said,
Good.
sorry, social care, occupational care, about I think as long as this is non-pharmacological, MDT
So no
education.
pharmacological, of course, we are stopping the culprit medication which we
Yes.
are thinking that it has led to the lymphoma. We are concerned about hydration. We are concerned about avoidance of nephrotoxic medication because the patient creatinine is already on the higher side. We are concerned about hydration status of the patient. We are concerned about the pain management, adequate pain management, and making sure that we are not offering NSAIDs because already the gut is inflamed and the kidney function is not good. And
Very nice.
we are quite concerned about if there is any malabsorption complication for the replenishment of those nutrients also.
Very nice, sir.
Now,
Yes,
yeah, please.
yes, sir. And safety netting. Here in this case, we do we need a safety netting, proper safety netting?
In the end, in the very
Yes,
end, first we'll be managing
yes.
this patient. Okay.
Nice, sir. Nice, sir.
So,
Nice.
after that, remember one thing I was forgetting to tell, that sometime there is association of Epstein-Barr virus also with PTLD. So it should be there in our mind. If it is there, we will be giving antiviral. But in our case, it's a clear cut, likely responsible, pathology. The factor is tacrolimus. So now, how to manage this? What you say, this lymphoma? So we are going for uh, what you say, rituximab. This is anti-CD20 monoclonal antibody, very famous for the management of lymphoma. Second is we are going for R-CHOP therapy. It's very famous. Rituximab with cyclophosphamide, doxorubicin, vincristine, prednisolone. It's a standard therapy. CHOP therapy, R-CHOP means rituximab with it. And then we are sometime, if it is localized or if you want to downstage it, we can also employ limited radiotherapy. And if it is confined disease, we can also get relief from surgery. Especially, it will be important if the other therapies are not, you can say, contraindicated of the disease if it is very limited. But the surgery role is, it is not well established. Most important thing is over there are CHOP therapy. Clear?
Nice, sir.
So again, considering it, so if there's an electrolyte imbalance, we need to manage it. If there's any kidney dysfunction, we need to manage it. Hydration. We need to adjust immunosuppressants. We have other option like cyclosporin, like mycophenolate mofetil, like prednisolone, like other options. But right now we will be avoiding tacrolimus. Also, it is nephrotoxic. Clear?
Nice, sir. Nice, sir.
Now,
So in
bit,
this case,
yes,
the patient is on prednisolone on the management plan. Or he is already complaining of 3 month history of diarrhea. So do we need to upgrade the dose of prednisolone as this is a stress diarrhea? In this case, do
this
we need
is
to that?
quite an important and pertinent question. So when we are stopping tacrolimus, we need to add on another therapy.
Nice.
Also, we will be considering this prednisolone also, that how we can be escalating it. But again, depending upon which and antisuppressant, sorry, immunosuppressant we are adding, say for example, you're going towards mycophenolate mofetil, whatsoever is, so you are titrating up the dosage of prednisolone also. Especially, it will be a rescue therapy in the cases when you are suspecting that my patient is going towards the failure.
Nice rejection. Nice. Nice. Nice.
Good.
Nice.
Okay, so let's have some supplemental discussion, then we will be concluding this session. Because this is a transplant case and this is a dual transplant, so few things are important for the consideration. So first thing which we can have the challenge which thing which can pose if the patient is taking immunosuppressive therapy, so we can have the question that what are the features of immunosuppressive therapy you are getting in this case. Steroids, I'm discussing common one. Steroids, say for example, can get paper thin skin, telangiectasia on the skin, proximal myopathy, moon shaped face, stria on the tummy, fractures, brittle bone. These are the common things with the steroids we are getting, with the derangement in the sugar levels and the blood pressure. Tacrolimus, tremors, acute kidney dysfunction, these skin cancers, lymphomas, of course, bad diarrhea is also the effect of tacrolimus toxicity. So tacrolimus toxicity is presenting with what you say loose motions, tremors, kidney dysfunction, and what you say the skin lesions and lymphomas. Okay, now we are going towards something called uh, just let me write it over there, cyclosporin. Cyclosporin along with the tacrolimus, they both can lead to derangement in the sugar levels and the blood pressure, exactly like steroids. Also, cyclosporin is not kidney friendly. Also, cyclosporin can lead to hypertrichosis, which can be evident in your patient. It can also lead to gingival hyperplasia when you are examining the oral cavity. Clear? My voice is clear?
Yes, sir.
Good. Let's go ahead. Question can be, what are the complications of the transplant? First, let's discuss the complications of renal transplant. Immediately divide it into three parts: pre-transplant complications, transplant complications, post-transplant complications. So pre-transplant complications, imagine what you can get in the renal transplant. It can be mismatch of donor and recipient at every level, HLA, blood grouping, all that stuff. It can be wrong selection of donor. Might be donor is already having kidney dysfunction and you're taking the kidney. Wrong selection of recipient. Recipient was not fit for the surgery, having some chronic debilitating pulmonary disease, might be heart failure, might be some communicable disease. So these all are the complications which will be there in the pre-transplant era. Wrong selection of donor, wrong selection of recipient with mismatch. My voice is clear?
Yes, sir.
Good. Transplant. What are the transplant complications of renal transplant?
Okay, such
It
as
can be
finish.
it can be anesthesia complications. It can be trauma to vital organs. It can be increased hot ischemia time and increased cold ischemia time, leading to the poor quality of the graft. I'm not going in the detail of it, it's slightly a transplant thing. Then it can be massive bleeding leading to ischemic insults. It can be hyperacute rejection, which starts when you are putting organ in the body and hyperacute process is immediately starting. Kidney body is not accepting it. Post-transplant complications. What are the post-transplant complications in the immediate period? It can be acute rejection. It can be vascular complication, where you were joining the anastomosis of the donor's vessels with the recipient vessels. Those sites can get thrombosed. It can be sepsis. It can be late complications, can be the thrombosis at the anastomosis site of the vessels is the early complication. If the patient is developing the stricture between the donor's ureter and the recipient ureter, is a late complication, usually taking months. And ultimately, you need to bypass that stricture. Of course, in the post-transplant complication, something will come that is immunosuppressive complications and massive infections. Clear?
Yes, sir.
Coming back to complications of pancreatic transplantation. Again, let's divide it into three categories. For our ease, pre-transplant, transplant, post-transplant. Pre-transplant, the same complications, same. Wrong selection of donor, wrong selections of recipient, communicable diseases. Then, during the surgery, cold ischemia time, hot ischemia time, which is increased. We can have this discussion later on someday. We're getting late. This is more linked with the transplant medicine. Then, during the surgery, it can be trauma to vital organs, trauma to the vessels. They are attaching it with the iliac vessels. Then, post-transplant. Again, in the post-transplant, you can get rejections. Immediate acute, then chronic rejections, then infections, then malignancies, then chronic pancreatitis, then recurrent diabetes, then of course hyperlipidemias. Then again, where they are making the anastomosis of the vessels, recipient vessels with the donor vessels, it can lead to thrombosis. Of course, failure can lead to diabetes and its complications, a common sense. So I think I have tried my level best to cover the maximum chunk of it. Of course, every talk is not complete. We need more discussions, we need more explorations, but I think that we have taken already 2 hours on this talk, so we should be winding up over there. But I believe that now you people are confident if you are getting dual transplantation, kidney and the pancreas, how to deal with it. In the summary, number one thing is evaluate the presenting complaint. Number two is evaluate the complications of the SAD comorbidities. Number three, check the working of the transplant. Number four, check if you are getting any complications of the transplant. Whenever you are dealing with the formulation of the DDs in the transplanted patients, try to think also about the drug effects, the immunosuppressant effects, the infections, HIV, AIDS, lymphomas. Then, of course, these patients can have some symptoms linked with the dysfunction of the graft. I hope everything is clear now.
Yes, sir.
Dr. Gailan, do you have any questions?
Sir, just before the last phrase, you said that approach to the dual transplant is first of all the chief complaint, and then about the problems related to the transplants themselves, about their functioning, about their complications. This is on the history
Yes.
or on in every step, in every step in history, in
In
exam and
every step, in
Yes.
history, in examination, in investigations, in management.
Yes. Can you kindly just repeat the stepwise approach? It was
Number one is evaluation of the presenting complaint.
nice.
Number
Presenting
two
complaint.
is, yes, whatever the patient is presenting, you have to make the DDs based on it. Number two, evaluation of the complications of comorbidities. Number three, accurate functioning of the graft. Number four, any complications if we are having with the graft, say for example, rejections. Rejection of the
Nice.
kidney will present with kidney dysfunction. We have discussed it. Rejection of
Nice.
pancreas will present with pancreatitis-like features, with the pain, with the vomiting, with the diabetes. Clear?
Nice. Very clear, sir.
So this is the approach. And this thing should be in our mind while taking history, while doing examination, while investigating the patient, while managing the patient. Because this is a special group. It's not a general population.
Nice.
And somewhere back in our mind, when we are making DDs, effect of immunosuppressants, effect of infections, effect of tumors, effect of failed transplant should be there in our mind. Clear?
Yes, sir.
Good. Anybody wants to ask any questions, queries, confusions, problems, issues? Any questions, any queries? You can use your hand option to come forward. Okay. If nobody is having any questions, I hope everything is clear and smooth and fine. We are concluding this session. Have a good night and goodbye.
Thank you, sir. Good night.